Right. So we will discuss about mainly diabetic emergencies. Just to recap about the different categories of diabetes and the abnormal blood glucose. But yeah, the important thing is that diabetes is a pandemic like the COVID pandemic. So wherever you go in the world, you might encounter people with diabetic emergencies. So that is another important reason why you should know about the management and recognition of these emergencies very well. Particularly in this part of the world, diabetes is becoming a huge problem. And you know that even in Sri Lanka, numbers are very high, and also the fact that there are a lot of people without diagnosed diabetes. So even someone not previously known to have diabetes might end up on your feet with a diabetic complication, or particularly like a metabolic uh, emergency. So particularly with increasing age, diabetes increases. We know that we are rapidly aging population, so this also makes things worse. So we are going to discuss two emergencies related to hyperglycemia. One is the diabetic ketoacidosis. The other one is called hyposmolar hyperglycemic status, or HHS. People used to call this HONC, or hyposmolar non-ketotic coma, but we don't use that terminology now. So when should you suspect someone to have diabetic ketoacidosis? If definitely somebody comes with ketoacidosis or coma, you should suspect diabetic ketoacidosis. Particularly if this is a person who previously had diabetes, you need to suspect more. But nowadays, since things are much more common, anyone coming in coma, acidosis, shock, or severe hyperglycemia, the person might have underlying diabetic ketoacidosis. You need to suspect. So what are the typical symptoms of diabetes ketoacidosis? They might come with the profound like shock, coma, but it might be milder than that. Particularly somebody with diabetes or even without that, nausea, vomiting, drowsy. They might have abdominal pain. Sometimes people have been misdiagnosed as acute abdomen when they came with ketoacidosis. Then also they get extreme fatigue. There may be underlying history of weight loss, hunger, and definitely increased urination. Uh, and just to recap on the pathogenesis, there is usually in diabetic ketoacidosis, uh, most of the time absent insulin. And also this may be made worse by counter-regulatory hormones like glucagon, which is increased, and particularly if this is in a background of sepsis or other stressful conditions like trauma, there may be increased cortisol, growth hormone, catecholamines, which are all anti-insulin hormones. And then what happens is this absent insulin leads to unopposed or uncontrolled fatty oxidation, fat oxidation, uh, and particularly breakdown of fat in the fat cells, which leads to glycerol and fatty acids. The fatty acids gets internalized into the liver, and there they are converted to ketones. And in addition, the glycerol and the muscle breakdown, which happens when there is absent insulin, comes all become substrates, good substrate for gluconeogenesis. So there is one hand increased ketone body formation, ketosis, and on one hand gluconeogenesis and glycogenolysis, which leads to hyperglycemia. So you have increased ketones and glucose in the bloodstream, which leads to the diabetes ketoacidosis. This diagram also gives further explanation, and particularly if you are asked to write an answer on the pathogenesis of diabetic ketoacidosis or hyposmolar status, if you know this diagram and if you describe this, you will get full marks. So if you go into diabetic ketoacidosis first, the basic underlying problem is absolute insulin deficiency. And I told you that there may be, in addition, increased counter-regulatory hormones. And then in this line, there is this unopposed lipolysis leading to ketone body formation, and also using out the alkali reserve, which leads to ketoacidosis. And then there is protein breakdown, and then which also, along with substrates from fat breakdown, supply enough gluconeogenic substrates, which leads to gluconeogenesis. And also I told you about glycogenolysis, all of which leads to hyperglycemia. It leads to glycosuria, loss of water and electrolytes, dehydration, and impaired renal function, all of which also leads to hyperosmolarity. And then combination of DKA, hyperglycemia, we call it DKA. And in particularly type 2 diabetes, the problem is relative insulin deficiency coupled with insulin resistance. So in that scenario, what happens is you don't get this problem, that unopposed lipolysis is much less in type 2 diabetes. The problem is this one, hyperglycemia. And in type 2 diabetes, this process can go on for a longer period than DKA, because of acidosis and ketosis, patients present early. But in hyposmolar status, this can go on, and the person might actually become more hyposmolar than in DKA. And that is why in HHS, the people have higher hyposmolarity than in DKA. Diagnosis, you need to have high index of suspicion of precipitating factors, particularly in previously diagnosed patients coming with the likely picture. Also symptoms suggestive of diabetes, which are recent onset. And I told you about anyone presenting with these features: abdominal pain, vomiting. Diagnosis, you need to demonstrate that the person has hyperglycemia, blood glucose more than about 250 milligrams per deciliter. And you should demonstrate some degree of acidosis, pH less than 7.3. And also you should demonstrate that there is metabolic acidosis by showing low bicarbonate, and also presence of either ketonuria or ketonemia. Now, this is a classification showing the differences between DKA and HHS, as well as different degrees of DKA. We don't usually at undergraduate level go into very great details about the different degrees of DKA, but it's not very difficult actually. In severe form, people are profoundly abnormal. They are in either stupor or coma. In mild, they are generally walking people. And then in the severe acidosis, pH less than 7. In mild, it is much less, pH usually less than 7.3, around 7.25, 7.3. And then, so anion gap, very high in severe, not that high in mild. But if you know about the clinical features like coma, stupor, and then you can distinguish between severe and mild. The moderate is in between. So in that way, you can remember this. Although we are not usually very particular about asking questions on this classification. Whereas HHS, you need to know definitely that they have higher pH than the DK, more than 7.3 by definition. They should not have very low bicarb, and also they should have hyperglycemia, usually very high blood glucose, but there's no obvious cutoff there. And then also they have very high serum osmolality, whereas it may be variable in DKA. They also can be having stupor or coma. So these are the things that you need to evaluate clinically. Very important to get a history to first diagnose and also to find out any underlying causes. Everyone should have capillary glucose who is presenting suggestive for DKA, because you can't waste time until you get the venous blood glucose. Then you can do serum or urine ketones. Usually the nitroprusside method is the urine method, but nowadays there are ketone strips. You can straight away start hydrating with your detection of very high glucose and also features suggestive of DKA. You don't need to wait even for confirmation. Hydration can start immediately. Then the arterial blood gases will give you the values for to confirm the DKA acidosis and metabolic acidosis low bicarbonate. The other ones are generally to find out complications or the underlying causes like complete blood count, urine analysis, then the blood culture, bacterial cultures, chest X-ray, ECG, then other things that we monitor: electrolytes, blood chemistry profile, and creatinine levels. Now coming to management. Now, if you know the basic pathophysiology of DKA and also the life-threatening things that if you mismanage, you can easily remember and properly manage your patients. Now, we know the problem is absolute insulin deficiency. So the patients will need insulin. At the same time, we know that this had led to saline depletion of water and electrolytes. So the patients will need saline, some form of saline IV fluids. And also, we know that patients are acidosis, so we know that there is need for correction of acidosis. And then with regards to the other complications that would arise in the management, it is hypokalemia that would kill the patient if you do not manage it properly. So because of the hypokalemia, which happens when you give insulin infusion to patients with very high blood glucose, we will not usually rush and give insulin to these patients. The first thing that we will do in the management is giving IV fluids. So what IV fluids? Usually we give normal saline to these people, but based on whether they are mildly dehydrated, severely dehydrated, or whether they have shock, then these things can differ, particularly in the ITU setting. Particularly if the person is in shock, they should need hemodynamic monitoring like CVP, then even colloids and pressure therapy. If it is usually severe hypovolemia, you can straight away give normal saline. If they have very high sodium levels, you can start half normal saline. But if they is generally normal, we give normal saline. But for your purposes, the mostly preferred first line fluid is saline, normal saline. But if you are going to be little smarter, you can also mention based on the patient, whether the patient is in severe shock or hypernatremia. These things can change. They are secondary. We'll have little additional marks, but small print. And then, are you giving normal saline or other salines all the way through the management? No. You change at some point. I will come to that later. Then coming to potassium, this is very important. The establishment of potassium status should happen very high up during the management of diabetic ketoacidosis. you should check the potassium as soon as you suspect. Because if the potassium is low, you should not attempt giving insulin because it will get further low and the patient might get a cardiac arrest. So if the potassium is low, you give potassium. You first replenish potassium with your normal saline. You will hold insulin and then recheck potassium. If the potassium level is normal, that is between about 3.3 to 5.3, then still you will give potassium along with insulin, because these people anyway would get their potassium shifted to the cells and they will become hypokalemic. So along with insulin you will give potassium. But if the potassium is high, like the potassium level is more than 5.3 milliequivalents, you will not give potassium but check potassium 2 hourly. So you need to know about this and write about this in an answer. The amounts are here. You might not really need to sort of by heart this, right? But you need to write the principles. Then is insulin, because even without insulin, when you correct the hydration, the metabolic derangement improves to some extent, because the renal perfusion improves, some amount of ketone bodies get excreted, some amount of acid buffering occurs in the kidneys, so the patient improves to some extent. But for definitive improvement, you need to give insulin. What is the insulin? You generally give short-acting insulin. On our setup, it's the soluble insulin that is preferred. What is the route? IV is preferred. What is the method? It's bolus followed by infusion. It is not IV boluses repeatedly, because we know insulin is very short acting. It has a very short half-life. So when you give boluses, it acts only for a short period. It should be initial bolus followed by infusion. Then what is the usual dose? It's about zero 0.1 units per kg bolus followed by the same dose per hour. Then I think in some of the guidelines, particularly in mild DK, they mention about rapid acting insulin subcutaneously. But for your purposes, don't try to mention in answers for that. But if the patient cannot be given IV, or until IV is established, you can give insulin intramuscular, right? You can give intramuscular insulin, because intramuscular also acts fast. But generally, subcutaneous route for typically shocked patients is not recommended, because the skin blood flow is much less. The insulin absorption is erratic. So how about continuation of insulin? If the blood sugar does not come down by about at least 50 to 70 milligrams per deciliter in the first hour, you increase the insulin infusion, you can double it. And when you go like this, the blood sugar starts coming down. Then what will you do? Will you stop insulin? No. You will reduce the dose, because just as the blood sugar comes down, it will not completely improve the metabolic derangement. So we need to deliberately give insulin for longer period, even when the blood sugar becomes normal. So to prevent that, what we do is we'll reduce the dose of insulin, right? And then also we will change your infusion, the hydration fluid to dextrose, right? So normally we give 5% dextrose or half normal saline, which has dextrose saline, both dextrose and saline. And then particularly when you are giving dextrose, you have to be further careful, because you can also precipitate hypokalemia. So you need to continue monitoring potassium and correcting potassium. What about correction of acidosis? The fact that when you give the fluids and give the other, change the metabolic derangement, your acidosis improves. But if the patient has very severe acidosis, like pH less than 7, you should not, protract this acidosis for longer, because it can irreversibly damage enzymes, change enzymes, and irreversibly damage organs like the heart, which can lead to irreversible status and multi-organ failure and death. So because of that, if the pH is less than 7, you will start bicarbonate. But if the pH is higher, we will not give bicarbonate. And these are the usual doses. If the pH is less than 6.9, we give about 100 millimoles of bicarb, and also along with potassium, because it will further reduce potassium. And if it is between 6.9 to 7, we give about half of that amount, 50 ml bicarb. So you need to know these things. And also, as if the patient does not improve, we can repeat bicarbonate if the pH is less than 7. So coming to the management of HHS, if you know your management of DKA, then it is just slight difference. The only thing that is not here is the giving bicarb, because we know that by definition HHS, the pH is not very low. So you don't consider giving bicarb, but you need to give the fluids more or less same as for DKA, insulin, same as for DKA, but here you might need higher dose of insulin, because these people with type 2 diabetes has insulin resistance. So you need to be understanding, and you should know that they might need higher dose of insulin. Potassium also same. Low potassium, you hold insulin and correct it. High potassium, you don't give potassium but check 2 hourly. Normal potassium, you can give insulin along with potassium correction. And then monitoring, same as for DKA, but there are changes. Particularly, these people are older people, so they have higher risk of myocardial infarction and vascular events, and also a higher risk of DVT. So you have to be mindful about these complications, and also get preventive measures like stockings. Sometimes in these comatose patients, things like low molecular weight heparin for prevention of DVT and things needs to be considered. Coming to complications. Complications can be complications of the disease itself or complications of management. The complication of management can lead to hypoglycemia, hypokalemia, and also when we rapidly change the internal milieu, the brain cells are still not fully kind of normal in the intracellular environment. So intracellular glucose can be higher. So this change in difference in the osmolality leads to the brain cells absorbing more water and swelling up, leading to cerebral edema, which is commoner in children. So in a patient with DKA, if there's initial clinical improvement with subsequent deterioration of their conscious level, you need to suspect whether this person is having cerebral edema. Now, that is about the DKA and HHS. What about management of blood sugar management of critically ill patients, particularly people who are in ICUs? The people who are in ICUs can have hyperglycemia due to diabetes, or they can also have stress hyperglycemia. People not previously diabetic now having high blood sugar, and also some of them might be on steroids. If their blood glucose is more than 180, we generally recommend to be started on insulin with a target blood glucose of 140 to 180. That is because uh, we don't want too much lowering of blood glucose, which can cause hypoglycemia and adverse events. We don't want too much high blood glucose, which will increase infections and bad outcomes. Now, I have a little bit more on a few things on sugar, like hypoglycemia. So I thought of even reminding you on this, although it's not part of the lecture. So hypoglycemia, again, reason for coma, altered consciousness, confusion. So anyone with these features, autonomic overactivity, we should suspect hypoglycemia. And also, since there are a lot of diabetic patients, it's also common. If you don't intervene early, they can have aspiration if they're in coma. They can get arrhythmia. They can get cardiovascular events because of arrhythmias, as well as they can have fluctuating blood pressure. And also, if it is severe, they can get convulsions, brain damage, and so on. So in the management of hypoglycemia, the principles, you should correct the underlying cause. If the patient is on insulin, still on insulin, you should stop the infusion. If the patient had taken uh, oral agents, you should stop the medications going further. The other thing is to, depending on the severity, you should either give glucose infusion or carbs. If the patient is unconscious, you should not give anything orally. Uh, you should give glucose infusion. But if the patient is conscious, can take orally, the aspiration risk is low, you can give glucose orally or even refined carbs like sucrose. But we have to be careful of rebound hyperglycemia, so you should not give too much of glucose for these people also. Because if you make them have hyperglycemia, then sometimes we see in the ICUs, then you give again insulin, then patient again goes into hypoglycemia and so on. You need careful monitoring, both for rebound hyperglycemia as well as, again, recurrent hypoglycemia, particularly if the patient has taken long-acting insulin or long-acting sulfonylureas and so on. And another thing that we can do for these patients is to give glucagon. Glucagon injection is available like a small pen, which particularly this treatment is given for people who have high risk of recurrent hypoglycemia. We teach their family members or carers or friends how to give uh, IM injection and give a glucagon pen. I think that is all that we have to discuss today in this lecture. This is a short lecture, and I can pick up some questions either through your the chat or by verbally if you want to ask questions. So there is already one question. Potassium replacement by same normal saline we give for volume resuscitation. We normally, ideally, it should be via a separate syringe pump, because the thing is, if you are hydrating through a peripheral vein, you should not give it through a peripheral vein potassium. And also, preferably this should be by a central venous line using a separate line, so that you can nicely titrate your potassium infusion. But sometimes in settings where there are no facilities to have a central venous line and so on, I know that people are given in the same infusion. Usually we can go up to about 20 milliequivalents per bottle of saline. Sometimes although that is not the best standard method, but sometimes this do happen. And then so the short term increase. Yeah, whatever, either it's short term or long term, if the blood glucose increases, it can lead to increased risk of infections. So even in patients who have stress hypoglycemia, it is substantially significant, like blood glucose more than 180. We tend to, correct it to between 140, 180. Somebody has asked whether there's a risk of ketoacidosis in keto diet. In normal people, actually, it's very much, not very high risk, but definitely people who are, having type 1 type of diabetes, and also who have, if they are in starvation, if they are dehydrated, actually they do not get diabetic ketoacidosis, but they can get what's called euglycemic ketosis, not the diabetic ketoacidosis. So somebody has asked in hypoglycemia whether we use 25% or 50%. That also depends on two things. One is the severity of hypoglycemia, um, and also availability, as well as whether you use a peripheral line or central line. Usually, peripheral line, we don't recommend giving 50% dextrose because that can lead to thrombosis and pain. Then we usually recommend giving 25%. And also, if there's very high, severe hypoglycemia, we will want to correct it faster, then we'll give 50%. And those are the reasons. Uh, Somebody has asked DKA occur only with type 1 diabetes. Actually, if you can remember that my chart, there is a overlap area. Even in type 2 diabetic patients, if there's too much of counter-regulatory hormones, they can lead to fat breakdown, and also particularly with infection, underlying infection, and so on. So sometimes we do see in diabetic ketoacidosis, very rarely, even in type 2 diabetes. Potassium is very, irritant. It's an irritant. That is why we don't give high concentration potassium via peripheral line. Somebody has asked whether the infection risk is high with the hyperglycemia or hypo. Infection risk is generally high with hyperglycemia, but if somebody has hypoglycemic coma, then you can have aspiration. You can have then, a lot of injuries if you have convulsions and so on. That is secondary infection, not, due to immune deficiency normally. Somebody has asked, is there a special benefit in giving high flow oxygen when patient breathing rapidly? I don't think that you need to give oxygen in DKA, because there's no issue of hypoxia, unless there is some other issue of, like, pneumonia and respiratory failure due to other reasons. But diabetic ketoacidosis per se is not an indication to give oxygen. Now somebody has asked, if a person has marginally high blood glucose level, when we diagnose diabetes type 2, can we use lifestyle modification without any medicine and observe? Actually, if you go by guidelines, international guidelines, they say to give lifestyle and metformin together for type 2 diabetes. This is the reason, maybe, my understanding is the reason they give is that the failure of therapy is high if you just give only lifestyle advice. Um, so that is why they recommend giving metformin along with lifestyle, even irrespective of a trial of lifestyle measures, which was earlier. Actually, if the failure of lifestyle measures occur, only that you go to metformin, but guidelines are different. But having said that, if somebody is very kind of determined, committed for a very strict diet and exercise plan, mild hyperglycemia. You can do it. It depends on the individual. Uh, so you can do it, but the guidelines say, I don't think that you will be asked whether you must always give metformin for mild hyperglycemia at the diagnosis if the patient is willing. So it's a thing that can be done, but the guidelines say you give metformin from the beginning. Does the type of insulin or drugs used by the patient previously matter in the management? It doesn't matter what insulin was given or what drugs were given. So you manage the DKA like this, and subsequently, once the patient stabilizes, you would revert to subcutaneous insulin first, again soluble subcutaneous, and then you get an idea of the insulin requirement, and then you put them on to further like a more predictable regime of insulin, maybe a combination of soluble and long acting like basal insulin, like that. But the management doesn't matter whatever the treatment they received earlier. Somebody is asking, is long time use cause beta cell exhaustion? This is a controversial actually topic. Some people used to think that long-term use of sulfonylureas would lead to beta cell exhaustion and beta cell failure. But some of the other studies have shown the inverse. So this is a controversial area, but where we are not very sure. Um, the thing is that in someone, particularly if having a very high blood glucose, when you give sulfonylurea, your blood glucose gets control and the glucotoxicity disappears, and that might improve some degree of beta cells. This is a bit of a controversial area. So patient who got DKA, do we have to restrict ketogenic food in their diets? I think if somebody has gone into DKA, I think you should not put them into ketogenic diet. Usually they should be on a non-ketogenic diet, at least in the initial periods until they get stabilized. And also people who go into usually DKA are generally thin people and might not even need the ketogenic diet. So this is, I think you have to be very careful in such people. And also particularly what happens is when you put them on ketogenic diet with very low carbohydrate, you can't give adequate amount of insulin for these people. So when you don't give adequate amount of insulin, that will also increase the risk of ketogenesis and DKA. So you have to be very careful. So somebody has asked, so somebody has asked, HHS and DKA given a regime on discharge, irrespective of their previous regime. But on discharge, of course, we will consider what they were on, given the regime. So at discharge, we will definitely consider what the treatment they were on, but most probably we will not send them on the same plan, but have a modified plan to prevent further DKA or HHS. So somebody has asked why HHS there is higher likely to have high glucose. I told you, because DKA more short term, it happens faster, and also they get symptoms due to acidosis and ketosis, so they present early, otherwise they would die. But in HHS, it is, it happens over time. They present late. So because of that, they will get higher osmolality than the in DKA. Any further questions? So in the absence of any further questions, then we will wind up, and hope you would have a safe time until we see you again personally, and all the best.